Hello everyone and welcome to our webinar today, Root Cause Analysis 101. Our presenter is Nicole Nash-Arnold. Nicole is a nursing career coach who helps great nurses transform into respected leaders. She shares her 15 years of experience in both senior and executive health leadership roles to germinate great leadership. Clinically, Nicole has over 10 years perioperative experience before moving into her nurse educator and management roles. She has postgraduate qualifications in perioperative nursing and currently a master's in nursing. Nicole is a member of the International Coaches Federation. Nicole, welcome to the microphone.
Thanks very much, Sue. So today we're going to talk about root cause analysis. It's a fairly common tool that we use in our industry to identify what goes on when we're having a problem. And in our industry, given that it is high risk in everything that we do, and we're dealing with some fairly significant consequences when it goes wrong, dealing with people's lives, then we need to have a look at what goes on and uncover those key drivers for those problems. So the things that might happen, and we're well familiar with the things that go wrong in our industry: medication errors, patient falls, failure to rescue, pressure injuries, hospital-acquired infections, the wrong procedure perhaps, handover miscommunications. There are any number of wayward incidents that can happen when we're looking after people when they are unwell. And like any medical condition that we look after, often these things that happen are actually only the symptoms. It's similar in an analogy that chest pain is not the cause of a problem, it's the blocked coronary artery that's the problem. And the symptom is simply the chest pain. When we find a patient that's got chest pain, then we run a series of diagnostic procedures to identify what's going on with that patient to cause the chest pain. And we will find, when we run those diagnostic procedures, the blocked coronary artery. And it's exactly the same when we have problems. If we've got a medication error, and it's a serious medication error, then it's likely that that is only a symptom. And we need to run a series of diagnostic procedures to identify what the cause is. In chest pain, we might do an angiogram. In an incident, we do a root cause analysis. That's our diagnostic procedure for how we go about finding what are the real things that are going on underneath the surface of these symptoms. If we don't look deeper, then this problem is going to happen again and again and again until we address those causal issues that are going on underneath the surface. If you have had a medication incident, for example, and you look back over 3 months and you suddenly identify a problem, then you've got to understand why, whether it's a freak coincidence, whether that same incident has happened over the last 3 months, or whether there's a deeper problem. You've got to get to the why of a problem, and by first understanding the when and the what and the who and the how, but ultimately coming up with the why. And that's what we're going to talk about today. We're going to go through that diagnostic procedure, which is the root cause analysis, and we're going to walk through that process step by step. So to that end, we're going to have a look at a particular scenario. Like I normally do when we go through anything like this, we'll take a scenario that wouldn't be outside the realm of one's imagination in the clinical setting and overlay the principle that we're talking about today with root cause analysis. And so in this particular situation and the scenario that we're going to run, then I'm going to take an emergency department scenario. So there are long wait times in this emergency department, and the triage times that are standard within Australia are not always met precisely within the parameters. A great majority of patients present to these EDs in considerable pain, like acute abdo pain, trauma, chest pain, lacerations, that sort of thing. The nurse in this particular situation triages a migraine presentation as a category 4, needing not to be seen within 60 minutes, but it takes 70 for this patient. In that time, their pain is 8 out of 10. The nurse is extremely rattled by the fact that this patient's in terrible, terrible pain, agonising pain for that period of time. And she finally gets a verbal order, but in her rush, she doesn't get the second RN to listen. The 5 rights aren't strictly followed, and the nurse walks alone to the cubicle and administers morphine, but hasn't checked the allergies and the patient is allergic to morphine. The patient has a considerable reaction. The nurse completes the incident report. For you, you're the person in the department that holds the portfolio for one of our 10 national standards for medication management and for the ward, so the NUM delegates the investigation of this incident to you. An RCA is something that you could use to have a look at this problem. An RCA has 3 things that it looks for, and it looks for the cause of what's gone on, and it usually falls into one of 3 categories: a physical cause, a human cause, or an organisational cause. A physical cause is an example of the actual physical dynamics of what's going on in the place that might have caused an incident. And in our situation in a clinical setting, it's likely to be equipment not being available that you needed for a particular situation, or that it was faulty. So perhaps you were doing cardiac monitoring on a patient and it failed to alarm that the patient was having runs of VT. And so there was a critical incident where the patient had an arrest because you weren't able to identify that early enough. That's an example of how we might say a physical cause was the nature of the incident that occurred. Organisational causes are reasonably common, probably the second most common. I don't think we have many physical causative situations in our industry. We're usually pretty skilled at preventative maintenance and checking equipment, and the emergency trolleys are always checked. But organisational causes are probably the number 2 out of the 3. And perhaps this is a faulty policy or a procedure. It's maybe a faulty business rule. For example, a hospital in this emergency department, perhaps, this hospital determines that they don't see children. That's their business rule and their policy that no paediatric patients are treated. But on a particular night, an acutely unstable paediatric patient may have presented to this hospital, and the hospital turned the patient away because the policy of the hospital is that we don't treat children. Perhaps there was a critical incident for that child where they arrested and had a potentially poor outcome on the way to the next hospital. It could be reasonable that you might find that under investigation that the hospital was found to not respond appropriately to their duty of care to that patient, and that what they should have done is treat, stabilise and then transfer. It's an example of how a policy is an organisational cause of an incident where the policy was faulty and didn't capture for that particular scenario, and people made a decision around a faulty policy. But then the most frequent reason that we find that we have problems, and I think in this particular scenario that I've just given you with the nurse who's given the morphine without an appropriate order and without completing the 5 rights in an emergency department, is the human causes. At the moment in our industry, there's significant chatter about the concept of human factors in our industry, and it's undoubtedly the largest factor that will cause error and harm in our industry. The Australian Quality for Safety and Quality in Healthcare have an excellent article which I'll make available in the notes of this webinar about those human factors. And the premise of the human factors is that our care and our core business is inherently delivered by humans, which are of course susceptible to human fallible and error, to human error. And it counters the argument that if a given nurse is highly trained, highly experienced and works hard, then they can perfectly deliver care and errors will be avoided. That concept of being perfect because you are highly trained, highly experienced and you work hard is clearly countered by the fact that human factors will take a role. And if history tells us anything about our industry, then we know that without a shadow of a doubt that concept of perfection and being able to perfectly deliver care is utterly false, and that we are all capable of making terrible errors. And why is that? Because human factors are a major contributing factor to adverse events. What minimises human factors are things like culture, a high reporting rate of incidents and near misses, discipline about optimising the relationship between human and technologies, that we look at lessons learned, that we have systems thinking around the way we work to make sure that we're effective and that we're safe human beings around our processes. And that's what an RCA can deliver, probably most effectively than any other diagnostic tool, is that it can look at all of the things that went on in a particular situation and find the one causative factor, but also all of the other factors that weren't necessarily directly the cause of an incident, but they were certainly contributing factors, and they give us an opportunity to have lessons learned as a result of that. So if we walk through the processes of our RCA, then our very first step is to define the problem. There are 5 steps when we're looking at a root cause analysis. Define your problem, then we go to collecting your data. And our next step is that we have a look at what our real causative agents are, what's really going on with this, what are our possible causative factors. Our step 4 is that we have a look at, identify from those possible factors what our root cause is, then we develop some recommendations and solutions. But first of all, we're defining the problem, because there are a lot of factors that go on in this scenario, and particularly with our nurse. There are a lot of things going on for our nurse. She was busy, she was stressed, we weren't looking after our patient within the Australian guidelines, and we were not following policies and procedures, and there were lots of things going on. But what exactly was happening at that time? That's what you've got to ask yourself in this situation. What is happening? What are the symptoms? When we hear about a garden variety medication incident such as this one, although it's a pretty serious incident, there was no valid order. That's what was happening. There was no valid medication order. In terms of the 5 rights, well, all of them were wrong because there was no valid order. But if we were going to specifically name one of them, then it would be the fact that the wrong drug was given to the patient as the patient was allergic to it. The Drugs and Poisons Act hadn't been followed, as 2 RNs did not go to the bedside. The nurse had widely deviated from hospital policy and procedure. Triage problems were clearly a problem. And we've got some symptoms of poor medication management, that it wasn't outside the realm of normality that a second RN wouldn't hear the order, or that the second RN wouldn't approach the bedside. In the rush to get things done, then we skipped a lot of the processes. So when we look at define the problem, then we've got some very distinct events that occurred. In a very significant or very complex problem or incident, defining the problem is incredibly important because it's often very emotion fueled. When you've had a critical incident and it's a really poor outcome, perhaps the patient has died, then it's often very fueled, and everybody's got an opinion and everybody wants to put forward about what they think could have been the shoulda, woulda and coulda. But to succinctly put down what exactly are the problems, and will hopefully de-emotion the situation so that you can clearly look at what the symptoms are and then work back from those. After you've defined your problem, your next port of call is collecting your data. When dealing with an incident, you've got to ask yourself, how do you really know that this is a problem? Now, in this particular situation, it's really obvious because the drug was delivered and the patient had a moderate reaction to it. So it is clearly unacceptable and there is clearly harm in that incident. But there are other times when there's an incident that may have been raised that is a problem, but why is it a problem? So consider a situation where this emergency department transferred a 13-year-old boy to the ward, and this hospital in particular doesn't see paediatrics. So the hospital that looked after this patient may have raised an incident report because outside the scope of what the admission criteria is. They looked at the policy and it says over 14-year-olds. And that their reason for that is that there was no one on the staff that had trained in paediatric advanced life support. And this was considered an incident. But if you ask yourself in this particular situation, how do you know that this was really a problem? And when you investigate, you discover the 13-year-old boy is 1 month from turning 14. He was 6 foot and weighed 65 kilograms. Then you have to ask yourself, why is this a problem? Is it the fact that the policy around admission criteria was faulty? And therefore you need to be more prescriptive around, or less prescriptive around, what is the cutoff point, or maybe it's not necessarily age, maybe it's weight, maybe it's a lot of factors. So sometimes there may be an incident raised where you have, or a situation that developed where you have to really ask yourself, why is this a problem? And that's what collecting your data is about. Collecting your data is about, this is what was expected and this is how it deviated from it, and it's a problem because there was harm or there was a significant near miss. And it's important to keep an open mind about why this is a problem. Now, there is a plethora of options in terms of the data that you may want to collect when you are considering and investigating an incident. So you may want to have a look at incident reporting trends. So you go back 3 months, 6 months, and have a look about whether that incident has happened previously and whether the circumstances were the same and whether you can see a trend that has been set. Infection control data can be very revealing, not necessarily in the incidental scenario that we're talking about, but for others, then having a look at your infection rates could be revealing. You know about your ward, but perhaps there's other wards going on where they're having higher incidences, or you can start to pick up some level of trend with those. Near miss data is useful. Patient feedback and complaints can be a really useful set of data. Looking at key performance indicators that most hospitals and health services will collect. Things like returns to the operating theatre, readmission rates within 28 days, door-to antibiotic time, door-to angiography time, the length of stay, can be really revealing. There is a number of key performance indicators, both qualitative and quantitative, that is collected in an organisation that you will be able to tap into by way of supporting or revealing some greater thing that's going on with your incident that you're investigating. Looking from a HR perspective, sometimes it can be really important to have a look at staffing patterns. What are the work hours per patient day? Are they higher than what they should be, which might reveal something that's going on? What specialing hours, well, how much overtime, how many no meal breaks have been triggered, how many call-ins have been triggered? Looking at turnover and retention and HR complaints might be indicative of what's going on in your ward. Perhaps in this situation there may be a real cultural problem that the retention rate is so low and your turnover is so high that the corporate memory, the people that hold this is how we do things in this ward and this is how we expect practice to be delivered, has been lost, and there is no semblance of what should be happening. National standard accreditation data is collected in organisations across the organisation as well. And there may be things like ward audits, your patient comfort, privacy audits, hand hygiene audits that is available for you to collect data on. Interviews can be a really useful way of collecting data and getting together with the key parties involved in an incident and effectively collecting statements from them about exactly what had happened. And probably in any incident that you're investigating, the interviews are where you start, and they are incredibly revealing, even in the nuances. Everything that you need to know will be told in that story, and you can go back to collect data and investigate further as your second port of call. But interviewing those involved is an incredibly useful source of data. Also, seeking expert advice can be really, really useful. You might be an orthopaedic ward and happen to be managing an oncology patient, and you really don't know. You know everything there is to know about managing the post-operative total knee replacement, but you don't know a lot about the expected care pathway for your oncology patient. So getting your expert together and say, what should have happened with this patient? And what should we have done? Is this reasonable practice? Can be really useful when you're investigating an incident as well. Your risk manager as well can be really useful with being an expert in terms of understanding what the should-haves in the situation and dealing with what actually happened as well. Have a look at your policy and procedure. Really incredibly important source of data so that you can match actual practice with what's expected in the policy and procedure. Perhaps the policy is ridiculous and no one follows that because it's asking for something that will take 10 times longer for no real patient gain, and no one follows it. And perhaps it's reasonable that part of your investigation reveals that that policy needs to change. You need to identify how long this problem has been going for when you're collecting your data as well, and incident reporting trends will help you with that. And they will also indicate how impactful this problem is. Perhaps your incident with the medication error is a 5 out of 10, but maybe then when you look at the other patterns, there's been a 7 and an 8 and a 9 out of 10 incident as well. So in our situation, we might use a particular tool, and there are lots of tools that you can use to collect data, but for this one I'm going to go through one called a CATWO. It's called a CATWO, and there we are. C stands for customers, A stands for actors, T for transformational process, W for worldview, O for owner, and E for environmental constraints. It was something that was developed in 1975 as a problem-solving methodology, and not all of those letters are particularly intuitive, but as we work through them, C is really your customers and who your internal and external customers that have been affected by the problem. The actors are who are involved in the situation and will be involved in implementing the solution. Your transformation process is what processes have been affected by this problem. And the worldview is what's your big picture? What are the wider impacts of this happening, of this problem happening? Who owns this problem, and what environmental constraints do you have to solving it? So if we work through that, in terms of your customers, your internal and external customers, then it's obvious that it's your patient. That's a no-brainer. But the team is affected as well. Anytime I've ever investigated an incident, the team live and breathe the weight of that incident for some time. It's talked about at the DD cupboard, it's talked about at the nurse's station, it's talked about in the tea room, it's talked about at handover. Have you heard about that incident with that patient that got the wrong morphine? It really does impact everything that people are talking about for some time. And any incident that results in patient harm, I think, really rattles the team and that nursing collective, as it should. But it's important to consider the fact that it isn't just the nurse and the patient in this story. There is a whole team of people that have been affected. And sometimes it's important to have a look at that as well, because it might be a chicken and an egg. Is the culture impacted and maybe the source of the problem? Or was the problem happen and then the culture? Was morale low before anything even ever happened, and therefore that was causing sloppy work? Or has the high incident rate is causing lower morale? It's an important part of the question. One of the things you need to consider while you're undertaking this diagnostic tool of a root cause analysis, it's very possible that culture might be a causal factor in this incident. And of course the hospital. The hospital is greatly impacted by the incidents of medication errors when they result in harm. They've got medico-legal considerations, their accreditation can be risk. Of course, sentinel events can result in negative media coverage, and private hospitals are licensed on the basis of how they track with these sorts of indicators. So your internal and external customers are going to be impacted in that way. But who are your actors in this scenario? Who is the main event? Then it's the nurse. It's the nurses that are involved in that process of not checking the drug and giving it to a patient without a valid order. In terms of what your process is, this is about considering what's been impacted here. What are the systems for your medication? processes. I mean, clearly policy and procedure was an issue in that it wasn't followed. And you need to have a look at that to see whether it's a reasonable policy and procedure. And in this situation, I think any policy and procedure around medication management is going to be reasonable, and the practice and what transpired was unreasonable. Certainly the Drugs and Poisons Act was a process that wasn't followed in this particular scenario. And the Australian triage scale wasn't followed either. This patient was categorised as a 4, should have been seen within 60 minutes, and at that point had not yet been seen, and it took 75 minutes. So there's another process that should have been triggered so that you can resolve the patient's greatest needs at the time, and those 3 processes weren't followed. When we look at the world view, that big picture sort of stuff, then it's clear that we've got something going on with our systemic problems in the way in which we're managing our workload. And the way in which we are managing our triage, and we can have a good look at how that's going to impact your patients. Obviously, it's impacting them significantly at the moment because we're having medication incidents that are causing harm. But the workload, when you have a look at the world view, it was clear that this patient presented to a very, very busy department. And when that happened and they weren't seen in the appropriate period of time, that ricocheted in a series of events. So that makes part of the aspect that you need to have a look at to ensure that when you are considering what's going on, then you are certainly having a good hard look about what that wide view is and the world picture for what's going on. It was a very busy department and it had a significant impact on the way in which people could deliver care appropriately. In terms of who owns this process, it's very clearly the nurses. They're the ones that are responsible. They receive an order, or should have received an order, and they deliver it according to the Drugs and Poisons Act, and they deliver it in terms of the policy and procedure. But also the doctors are required to see their patients within those triage times, so they have a part to play in terms of owning this process. And there is plenty of evidence to say that there are a lot of things going on here that resulted in this incident, but nevertheless the owners of this are mainly the nurses, with the doctors have some part to play as well. Environmental constraints is about having a look at what your physical location. Are there things in the physical nature of the way things are operating that you need to consider? And it's possible that your physical emergency department in this situation was just too small to cope with the patient surge that happened. So if you had patients in the corridor and you had multiple patients out in the waiting room waiting to be treated, and you had patients waiting for beds, then clearly the physical nature of the way in which this workflows were set up was going to be a problem. Workload was clearly a problem. Then there were too many patients to see them within the appropriate time. And when you do your investigation and you gather your data, then bed block was a problem. Not being able to get patients out of the emergency department into the ward, you found to be an issue as well, and that significantly contributed to the fact that we couldn't see patients within those appropriate timeframes. So you have a look. They're the sorts of evidence that you need to gather when you're collecting your data. You work through your customers, your actors, your processes, your big picture, who owns this process, and your environmental constraints, and you find your data to match that. Incident reporting trends, your flow data about how patients are moving through the organisation, what your triage times are generally for the last 3 months, what the time to transfer is. Incredibly important one, and this one is door to analgesia time. How quickly are patients getting their analgesia time? Because that might have been one of the major factors, is that there was such pressure for nurses to execute that KPI. The patients are getting their pain managed, but they're not necessarily getting their medical review in time. Then that was an incredible factor in this picture. So you gather your data. Once you've got all of your data, then it's time to have a look at what are your possible causal factors. You've got many. When you look back at this, you've got many things that could be a cause and the number one cause. But what you need to identify now is paint a picture of how deep this problem goes. It's important now to have a look at the whys. You've now got the what's happened, you've got the who was involved, you've got how it happened, and you've got when it happened. And the trick about this process is then really drilling down on the why. And there are a number of ways that you can do and approach this, and there is a number of strategies in the literature about how you might investigate. And we'll go through one of them. But one of the important things is that of all of these, there are some of these that will be lessons learned and some of these that will be causal factors. And that's an important part of this is that perhaps the policy and procedure was an important lesson learned because it wasn't perfect for this particular situation, but the real problem was something else. So you need to understand exactly what that is. So there are a couple of ways. The appreciation method, which is just so what. When you're going through this process and you identify each of those problems, your policy and procedure, so what? Really asking that, what is the significance of that? The 5 whys is what we're going to work through for this particular one, and I've dealt with that one before. There's the drill down that you just keep drilling down and go through the process of each layer upon layer. And there's a cause and effect diagram, which we'll also go through with this one as well. But first of all, we're going to have a look at the 5 whys. And it's an incredibly useful process of really getting down into what is the causal factor in this particular situation. So your first question in this situation might be, why was the wrong medication given? And the answer to that was because the 5 rights were not followed. Why? Why were the 5 rights skipped? And the answer to that is because there was no order written for the drug. Third why. Why was there no order? Because the patient had not been seen and was in 8 out of 10 pain for over 70 minutes without any analgesia. Fourth why. Why had the patient been in pain? Because they hadn't been yet seen by a doctor. Why hadn't they yet been seen by a doctor? And the answer is because our triage times are always longer than average to be seen. So ultimately, I think we're now at the true cause of this problem, that the patient hadn't been seen and the nurse was rattled by the fact that they were in excruciating pain, so we cut corners. So the non-compliance was because they had to have analgesia, but they didn't necessarily need their full medical head-to-toe evaluation. At this stage, they needed to know that they were safe to have an analgesia to get their pain under control. So it's an incredibly useful tool of going, yeah, sure, the 5 rights weren't followed. That was obvious from the get-go. But why? And ultimately, it's a workflow problem with the way in which we're delivering care because the triage times are not being able to get the doctor there in a timely manner for their most significant need at that particular time. The other way you can look at this is the cause and effect diagram. And the cause and effect diagram is probably useful in this situation more than the 5 whys because it is multifactorial and there are things going on over the top of other things. It's a little bit like a mind map. Sometimes you can present it like a fish diagram, but you go back to your cat woe and you've identified the 3 major things. There was a systems problem, there was a workload problem, and there was a daughter analgesia problem, I guess. So a systems problem in that we had a triage time and we didn't meet it, and that caused the patient to be in pain and the nurse rush to get analgesia. There was a workload problem in that this particular nurse and the other nurse were so overwhelmed by the number of patients in the department, they had bed block, they had patients trying to get into the department, that they cut corners. The second nurse didn't check the order, the second nurse didn't go to the bedside because that second nurse was rushing off to get her workload done. So there's clearly a workload problem. And there's a door to analgesia time problem in that we've nailed one KPI, which is an appropriate KPI to nail. You really want patients who are coming in an 8 out of 10 pain to get their analgesia. So we've ticked that. But we have radically failed on our triage time, and we've radically failed on the safety of our patient in terms of the way in which we deliver that analgesia. The next part of that process is then to drill down on what are the things that go with that. If we're going to go, these are our three main problems, and what comes off that? What are the things that are affecting that? Our systems is our deviation from our policy and procedure, that we didn't follow the Drugs and Poisons Act and we didn't follow the 5 rights. So we've got a systems failure there with the way in which we're delivering that process. Our workload is that our triage times are blowing out because of our workloads are so high, and that we're in bedlock and we can't get patients out so that we can get them in so that we can see them in an appropriate time frame. And the door to analgesia time is obviously creating a lot of stress and a lot of pressure for this particular registered nurse and probably the team collectively. They feel an immense sense of pressure to be able to settle their patients from a pain point of view and provide that intervention that they know that they can. They're delivering narcotics as almost every single patient that walks through the door, so they know what they need to do. They know that this patient needs morphine and they know that they need it quickly, and the sooner that they can get it, then the sooner the patient's going to be on their pathway to a positive outcome. So it's easy just to go, well, they're going to get morphine, so let's just get it on and get it over with. But not at the cost of systems. So that cause and effect gets to on one page to be able to see all of the things that are going on, whereas our 5 whys tends to look more in a more linear manner. And it's a good simplistic process for looking at one particular problem and drilling down to that causal effect and to look at each factor. But to present it more universally, then the cause and effect diagram can be much more impactful with capturing all of the factors that are going on for your situation at that particular time. So now we've identified 3 main factors that's going on with our incident in our root cause analysis. And so now we're going to identify the actual root cause. You've got a list of what your causal factors are that have all contributed, but it's important to identify what the real reason is. If I was investigating this incident and I was looking at that cause and effect diagram or the 5 whys, at the end of the day, I think the real reason it happened is non-compliance. The RNs need to follow the 5 rights, and the RNs need to have a valid and legal order before administering a narcotic. That's a non-negotiable. That's where the solution should sit, that we have compliance around the Drugs and Poisons Act and our policy and procedure. But at this point, if that's the root cause, don't discard the other findings, because there's an important lesson that you can focus on and demonstrate some real improvements for the way in which you deliver care in this particular setting. Because there's not just where the incident happened, there's other potential incidents that are growing in that, what you've found. Clearly bedlock in this little department is increasing workload, and clearly workload is increasing the triage times. And those triage times are delaying getting patients to the bedside to deliver care. So they're the things that you need to sort. It's important lessons learned, but it's not necessarily the root cause. But to focus on those is incredibly important so that you can take those minutes, prevent the incidents that are growing from those problems. And some of those are complex problems to solve, but it's important to take that opportunity to prevent being in this situation in a couple of months where you're identifying the root cause was your workload. But ultimately you've identified your root cause, which is non-compliance with the Drugs and Poisons Act and your policy and procedure. So step 5 is recommendations and solutions. Now, this is the where to from here. What will prevent this from ever happening again is what you are working out in what your solution is and what you're recommending when you move forward. How should this solution be implemented? who is responsible for it, and what are the risks and the downsides of rolling this solution out. This is actually a really excellent time where down the track, after you've resolved what your solution and your recommendations are, is to take one of these as a project. And I've recently done a webinar on project management where this would feed into that. You've got your solution, you've got your recommendation, and now you flick out of the root cause analysis mode and you move into your project management mode and you roll that solution out in that framework. But for this stage here, it's about identifying what you're going to do about the problem at hand. Look back through your cause and effect process and consider what your changes are going to, how they're going to impact. If a policy said X, then Y should happen, and you're going to fix the policy so that it's appropriately reflective of that. In this particular incident, I think one of the solutions, obviously the RNs involved need some level of counselling about compliance with the policy and procedure and the Drugs and Poisons Act. But think more broadly about that. Is that going to stop this happening again? It's likely that the two RNs involved will probably never do it again. But if you've identified through your investigation in the incident trending that has happened, that these sorts of incidents have happened before in varying degrees, then just talking to those two individuals is not going to solve the problem. Then there is obviously a broader problem. And you may find some solutions when you do some clinical research and a literature review, for example. And in this particular situation, perhaps one of your solutions is implementing nurse-initiated narcotics. In the research that you've done, in your literature review, you may have found the research there where that has a significant impact on being able to deliver an intervention very, very quickly with nurses who are appropriately trained, who have done a competency and understand what particular patients and the contraindications for the patients that can have narcotics, and particular narcotics. You don't want to be giving morphine to a patient with a bowel obstruction, for example, and through a competency development program, then they would know that and be able to initiate morphine safely. Because ultimately what you found is that the triage times are blowing out, and you can't get a doctor to do the full workup, which one of the outcomes will be analgesia. So to bypass that, under certain circumstances, you can nurse initiate morphine, and that will solve that problem where you're not waiting for the doctor. And you can deliver care to a patient who is clearly distressed and writhing around in 8 out of 10 pain. It will take the workload pressures off and the stress of a nurse watching his or her patient in that unbearable pain. And that might formulate part of your recommendations and your solutions moving forward, so that you roll out this self-directed learning program and competency program for all registered nurses in this emergency department, and you ask yourself the question, will that prevent this problem from ever happening again? And it might be your judgment that the answer to that is yes. And how shall a solution be implemented? So you've thought a self-directed learning package and a competency program is how this should be implemented. Who is responsible for it? Then you need to find out who it is that will champion that project, and what are the risks and the downsides of rolling that out. Clearly there are lots of risks, and it's likely that people feel differently about the nature of nurse-initiated morphine, and that's part of the exploration of that document. But you certainly need to deliver those recommendations into the decision makers of your organisation after you've been asked. In this particular situation, you were asked by your nurse unit manager to investigate. So you would prepare some sort of briefing paper with all of your investigations, and it would include your cause and effect diagram, whether that's presented in a mind map or presented in a fishbone diagram. You might present your 5 whys. You would present your CATWO about the evidence that you have collected on what has gone on. And you would present your recommendations and your solution going forward. And most importantly, a good opportunity to document your lessons learned. That bedlock is an area where we need to spend time concentrating to resolve, because that was a contributing factor. It wasn't the root cause, but it was a contributing factor. and certainly the fact that patients were not being seen in an appropriate time, we weren't meeting our triage category times, that was a contributing factor, but it wasn't the root cause. And all of those need to be documented so that we can progress those alongside of this project as well. So ultimately, after that, then you've got yourself a project, and you can move on to that managing of that project through that that scaffolding that we've talked about in a previous webinar as well. And this would perfectly fit that process. But when we started this, we were undertaking a diagnostic tool to find out what the symptom of a medication error was all about. And through this process, you've identified that non-compliance due to workload, and you've identified an excellent solution that you think will be incredibly useful and that will deliver safe patient care and safe outcomes. In my on my website here, on that web address, for those of you who would like to know more about some of the things that I've talked about here, then I've got a copy of the this recording as well as the slides of this presentation, but also some of the tools that you might use for this. So we've talked about the root cause analysis and the 5 whys and the CATWO, but there are other tools that I've included in there that are more useful and applicable depending on the situation that you're investigating. And also that document from the national standards about human factors. That's ultimately often what is the root cause in our situation, is no matter how well trained and how experienced and how committed a nurse might be in a given scenario, you cannot be flawless, and there is always going to be an opportunity for the Swiss cheese to line up, and that problem occurs. And human factors is something that has taken shape in our industry after it has radically changed the face of aviation, because no matter how trained and well executed a pilot might be, there are the human factors that result in error, and it's exactly the same for us. So it's a really important part of the root cause analysis, because I think in our industry it's most likely where you will find most of your problems. So I hope that's helpful, and that more help is available at that link there.
Nicole, thank you very much for a very interesting presentation. That was great. I love the analogy of the holes in the cheese lining up.
Yes.
That was very clever, very clever. And it is, I love the way you apply business methodology to a clinical setting, because it fits in so well once you understand the science that sits behind it.
Yeah, and most of these sorts of tools that are used in, any industry, but a lot of business settings are core business for what we do. When you realise, particularly, human factors and applying, root cause analysis to these sorts of problems. It's things that we see in our wards and in our communities and in our aged care settings every single day.
Yes, certainly. Certainly do, and I will be going to your website to download that paper so I can have a read. It sounds very interesting.
Yeah, it is. It is interesting.
Excellent.
The human factors thing is definitely getting momentum.
Well, look, as we've said before, if you could take the human element out of what we do, it would be such an easy system. But you can't. We're a human-focused service, whether that's humans providing the service or humans seeking the service out. And
I've often, I've often shared coroner's reports with my staff and people that I've come in contact with, and it's just so what you've said, if you could take the human out of those situations so many times. And I often put myself in that situation and think, would I do that in that coroner's case? Is that a mistake that I might have made? And some of them are, they are amazing, and you can definitely say no. But there are other times where you could really say, yes, I might have made that mistake. I can see how that might have happened. And I think we all
Because when
consider
you've got
ourselves.
all those variables on your shoulders
Yes.
and you're trying to tick all the boxes and be everything to everyone who needs you to be that at the time,
Yep.
you can, there are times when you can understand, well, poor darling, but I probably would have done the same
Done the
thing.
exactly same thing. I agree
You
with
know,
you.
hindsight's a fabulous thing to have.
Mm. And there are
But
lots of times when you're blindsided by, distractions or expert error. That's the irony of the two nurse checking, is that they inherently trust each other and say, oh, they've checked it. They're excellent. I don't need to look at that, morphine ampule, and they've got something else out. So, expert error is something that can be, one of those incredibly diabolical human factors that do just that. If we could take the
and
human
that,
factor out, we wouldn't have a problem.
no, that's exactly right. And that's also happens sometimes, when people, you're doing a grand round or something,
Mm.
and everyone's looking to the specialist
Mm.
and they say something that is actually flawed. Like they're talking about
Yes.
the results from the chick in the next bed,
Yes.
or they've
Yes.
totally got something wrong and no one is saying anything.
Anything. I know.
Because that specialist is seen to be the penultimate authority. So you question yourself before you
You,
question them.
that's an excellent example of the human factor of, oh, I don't think that's right, but they must be right
Yeah.
because
Yeah, I mean,
they're them. So who am I to
this guy,
say?
that's it. And then it's not until it eats at you, and then it's usually the youngest member of the team sitting around the bed that will put their finger up and say, "Oh, I think we
Oh,
might
no.
not have it right here," and they get the look of death, and the registrar
Absolutely.
finally thinks, "Oh, okay, that's right," and
Yes.
takes over. But very interesting times when that happens.
Yeah. Yeah, no, I
Nicole,
agree.
thank you very much for a fabulous presentation. Today we have been listening to Nicole Nash Arnold from Nurse Manager HQ, and I recommend their website to you. To everyone who's listening, I wish you an absolutely exceptional day, and I look forward to seeing you online at another webinar very soon. Goodbye.